It's an honor to be here in ICP and in Japan for the very first time. Um, my name is Reem Leif and I'm a graduate student of counseling psychology and a teaching assistant at the American University in Cairo. Today I'll be presenting my paper about chronic pain, and it's titled A Theoretical Understanding through 5 pain-related psychosocial constructs. So, as a background, I'd like to differentiate between pain and chronic pain. So pain is simply defined as an experience that involves a neurophysiological component and then an affective response to it. So basically you have an inflammation and then you feel the pain. This is simply the experience of pain. Chronic pain, on the other hand, is defined according to the International Association for the Study of Pain as an experience of pain that lasts for at least 3 months. So basically, it's just the same as pain, but you have 3 or more experiences over an unremitting period of time. For me, I think this is an underestimation of the complexity of chronic pain, and that's why I've decided to examine this phenomenon. So this was my research question. What are the proximal and distal factors, psychosocial factors that mediate the experience, the subjective experience of chronic pain? I'll try to answer this question through the examination of each of these 5 pain-related factors: chronic pain beliefs, perceptions, communication, coping, and finally, behaviors. So when it comes to chronic pain beliefs, these are 3 examples that are found in literature. So for example, in tribal South America, it's common to think that older women are more likely to suffer from pain because they have higher social responsibility. In the Hindu culture, some people may perceive pain as a fair karma, so you just accept it. In my country and in many other Muslim cultures, we perceive pain as thawab. Thawab meaning that if you endure the pain, if you are patient, then God will reward you. So this is something to be embraced. As you can see from the previous examples, it's clear that pain beliefs serve functional roles within the context where pain manifests. So in this when it comes to pain acceptance, we also have to understand that all of the pain beliefs, like these ones, they guide the patient either towards pain acceptance or demoralization. But in the most case scenario, a patient or a client needs to find a position somewhere between pain acceptance and demoralization, because in many cases, it's a lifelong experience. So he or she has to deal effectively with it. This is very relevant to Barnard's existential paradox between hope and despair. So someone with chronic back pain, how would he or she deal with this experience? Again, this is very culturally influenced. When it comes to the second pain-related variable, this is perceptions, chronic pain perceptions. I define perceptions according to Melzak's pain bureau matrix, meaning in terms of subjective pain severity and location, both as reported by the patient. In many cases, patients go to, at least in my country, in my culture, patients with psychosomatic problems, they present to physicians, general physicians, not psychiatrists, and they do so for a very long period of time. So whenever they present to a physician, the physician decides to conduct some investigations which then yield negative results. In this case, the patient feels invalidated because he or she feels the pain, is actual pain. So in this case, the patient looks for some cultural explanations to justify his experience, such as this is because of the devil, or it's thawab, or it's karma, or whatever, some cultural explanations. And I think that such cultural explanations can be, or the search for some cultural explanations can be regarded as one way of chronic pain coping. This is how they decide to cope with this ambiguous situation that has no label, no diagnosis, nothing. On the neurophysiological level, the patient may get into this pain trap. So he or she feels pain sensations, which then activates the limbic system, the amygdala, and which then triggers some responses and attentional focus on pain. And thus, there is more and more activations, more pain sensation, and it's endless. It becomes like a vicious circle. One thing that makes this cycle even worse is the idea of demoralization. So the patient feels as if he's trapped in this cycle forever. So this is how bad it can be. It's not just a 3 months or more period of time of suffering. No, it's much more complex than that. My third variable is chronic pain coping. And well, it makes sense. In order to cope with chronic pain, you have to have some chronic coping strategies too. So again, these coping strategies or techniques depend so much on the individual variables and the cultural variables. And this is a very interesting study conducted on 3 groups: African Americans, Hispanics, and whites. So they examined their coping techniques, and they found out that African Americans were more likely to use praying in order to cope with their chronic pain. When they examined the same exact coping technique, which is praying and hoping, they found out that the composite score was only significantly negatively correlated with African Americans, but not Hispanics or whites. Meaning that even if whites or Hispanics used the same exact coping strategies, it was less likely to be effective in reducing the pain intensity. How do we explain that? It's basically the faith in the usefulness of the coping strategy. There is no one strategy that is functionally better than the other. It's all about how relevant it is to the patient, to the individual, and the context in which pain manifests. My fourth pain-related variable is chronic pain communication. So just like any narrative, any experience, chronic pain is an experience, is a narrative that needs to be constructed and communicated. So chronic pain is mainly constructed between patients and clinicians. However, it's not limited to the clinical context. For example, in my country, the family plays a vital role in determining the chronic pain narrative that the patient adopts. So again, it's not limited to the clinical context. When it comes to chronic pain communication, we have 2 scenarios. Either that the patient needs to communicate his or her pain, or does not need to do so. So when does a patient need to communicate his pain? These are 2 cases where this is the case. So sufferers may need to justify their pain-related behaviors, meaning that in situations when a patient may find it difficult to sit down for long periods of time, or when he or she wants to avoid some judgmental responses from others, like being labeled as disrespectful for leaving in the middle of a meeting and all that. So these are some examples when pain needs to be communicated to justify the behavior. Sometimes, on the other hand, the pain needs to be repressed. This is basically when there is disapproval of the complaining behavior, or lowering the social spirits. In my culture, sometimes people link pain to lack of religiosity. So this is very judgmental. So in this case, patients would not choose to communicate their pain or talk about it. This is also the case when the feedback is unpredictable. And a very good example of a case when pain does not need to be communicated is that of US female veterans who chooses not to talk about their pain in order to keep serving the army. If they don't, then, they fear ostracism.